Hello, and welcome to the second in this COPE series of medical student presentations, where they have the opportunity to share the value of their educational experiences in addiction medicine. These presentations are part of an ongoing effort to amplify student voices and foster dialogue on complex healthcare challenges that intersect with the public health and social justice. This program is funded by the Opioid Response Network and presented by COPE, the Coalition on Physician Education in Substance Use Disorders. COPE is a voluntary organization devoted to improving patient care and the public health by ensuring that all physicians are trained to prevent, identify, and provide specialty appropriate interventions for patients with substance use problems. I'm Dr. Steve Wyatt, the COPE chair, and it's my honor to introduce University of North Carolina fourth-year medical student Courtney Quick. Courtney will be sharing with you her experience in both clinic and community settings and how they shaped her understanding of addiction, recovery, and the responsibility of the healthcare system to engage more deeply with this vulnerable population. It's my pleasure to welcome student Courtney Quick. Courtney, take it away.
Okay, so like you said, I'm Courtney. I'm a fourth-year medical student at UNC, and today I'll be talking to you about my experience in medical school with addiction medicine, and most recently an elective I did in Asheville on substance use disorders. Title is called No Way Out, but Through Medical Students' Perspective on the Roles of Clinic and Community in Treating Opioid Use Disorder. Here are the disclosures. So like I said, my name is Courtney. I'm from Asheville. I came to medical school really for addiction medicine. It's something I've always been really passionate about. And right now I am in the process of applying to medicine and pediatric residency. So a word on my former education in addiction medicine. During the first year of medical school, we had a few days of addiction medicine specific lectures in the psychiatry block. It really wasn't a ton of information, just kind of a broad overview. We had the most valuable thing we had, I thought, was the two small groups that were led by women in the UNC Horizons program. That's a program that UNC has for people who are pregnant and using drugs, and they had participants in this program come talk, and I thought that was just a really awesome experience and probably the most valuable thing UNC has done to teach us about addiction. I was the addiction medicine interest group co-lead, and so as part of that, we kind of we had a Narcan training, we had different doctors in addiction medicine come speak to students in our class that were interested, and that was a great experience. A lot of my third year rotations involved addiction, even if it wasn't clearly, like even just on internal medicine, there was a lot of alcohol use and other things that gave me exposure. I really recommend this Curbsiders addiction medicine series. That kind of helped me supplement with what I was learning on rotations. And then what I'm talking about today is the fourth year substance use disorder elective. So this is kind of like an overview of the weekly schedule that I had during this elective in Asheville. I would do some office-based opioid treatment, so primarily Suboxone, seeing people get prescribed or buprenorphine. I went to a methadone clinic on other days. My favorite days were the peer specialist days where I went to a peer recovery community center. And then I also did some shadowing or kind of time at the state-operated inpatient detox center in Black Mountain. This is just to kind of make sure everyone is on the same page, an overview from the Curbsiders Addiction Medicine about medications for OUD. Buprenorphine and methadone are the ones that I saw most frequently. Naltrexone, I think in medical school, I felt like this wasn't talked about a ton, but I think it does have more data for it, and I am interested in seeing that being prescribed more, and as I don't have that much exposure. buprenorphine is the most common one I saw, the partial agonist, and then methadone being a full agonist. I don't think I understood before that for opioid use disorder alone, methadone cannot be prescribed outside of a methadone clinic. And so that is very different than buprenorphine, and kind of, I'll talk about that in a little bit. But it's important to know that methadone can be initiated in the hospital, and it can be given in the emergency room as part of this effort to lower the threshold to get people into addiction medicine treatment or addiction treatment. So the office-based opioid treatment, just a little overview of that as well. Bup comes in a few different formats, films, tablets, and then more recently, these long-lasting injections, which I think is really great, especially for people that don't like taking pills every day, or that they feel like that is a addictive behavior, which I've had a few patients share. And then a word on just the idea of precipitated withdrawal. Because buprenorphine has such a tight affinity for the mu receptor compared to fentanyl and other opioids, it can knock off any residual fentanyl that's been hanging out in your fat stores, in your blood, and then that kind of can theoretically cause precipitated withdrawal. And I think that is a barrier to initiation, and it, doesn't make people feel good. But in some ways, I think this rotation showed me that a lot of times you just need more buprenorphine in those situations, and that in the age of fentanyl, I think we're doing higher dose titrations when we start people on buprenorphine to try to avoid that, because once they're already kind of feeling precipitated withdrawal, giving them more buprenorphine, just trying to increase the amount of the partial agonist effect, I think is the most helpful. But some people really want to do that in an inpatient setting, and outpatient is not the way for them to start. So that's why I mentioned here microinduction protocols, where when someone is in detox, they can continue a full agonist opioid, either like they're trying to switch from methadone to buprenorphine, or the hospital can give a full agonist opioid, and then they increase buprenorphine ever so slowly throughout to try to avoid precipitated withdrawal. That cannot yet be done in the outpatient setting, as you can't really say like, go just continue using fentanyl and we'll increase your buprenorphine. So that's kind of a benefit of inpatient detox. And then I didn't really know that there's some adjunct medications that are really helpful for just anyone experiencing the symptoms of withdrawal, like clonidine, hydroxyzine, and gabapentin. 16 milligrams is kind of the dose where the amount of receptors that are occupied by buprenorphine confers a protection against fentanyl overdose and that respiratory depression. And so oftentimes the wonderful nurse practitioner I was working with would want her patients to get at that point 16 if they're using Suboxone as a way to not use fentanyl. And there's always that risk that they would return to use, and she would feel better that they were protected with that. And then part of this office-based opioid treatment is peer specialists, counselors, and social workers that all see the patients as well during the appointments and have their own special relationship and bond with patients that I think really adds to the overall care. Some pearls, I think there were a few times where it was just clear buprenorphine is not going to work for this patient, and that's okay. Methadone is another option, and being able to talk about the differences and why that might be a better option for someone is important. A really big part of something I learned was just the urine drug screens. They are a tool that is used a lot in both the methadone clinic and in the buprenorphine prescribing clinic. And I think just how I like to see providers do it is they would just open up their screen with patients and be like, hey, this is what the urine drug screen showed. This is our objective data. And then, based on what the patient says and shares, you can order confirmatory testing. And oftentimes there are false positives, or you do the confirmatory testing and that drug isn't there. And so I think your job is to take someone at their word. And I think that that's part of the therapeutic relationship. And so I think there was a time in which urine drug screens were used as like a punitive thing and to cut off people from treatment. And that is not really how it's going anymore. And I think that's correct and really is like aligned with patient-centered care and safety-focused care. And then I saw this, the provider I worked with too, she would still have boundaries, even though she wanted to do safety focused care and risk reduction and acknowledge that patients use drugs still. She would have boundaries of, I'm not going to keep prescribing benzodiazepines for anxiety. If you're testing positive for fentanyl, there's a risk for respiratory depression. And so I think it's helpful to see how different providers maintain boundaries with their patients while still not being like paternalistic and punitive. The methadone clinic, again, the UDS, the urine drug screens are important here because that would a lot of times guide how often those patients have to come to the methadone clinic and whether or not they can get take-home dosing. I saw a few patients that, they only had to come once a month or once every 2 weeks. And that really makes a difference in they're able to, do their job and take care of their kids. I think obviously that seems better if you're not going every single day to a clinic. And so that's why it's important to, when you get an unexpected urine drug screen result, you're talking to the patient and order confirmatory testing because it can be pretty jarring for a patient to go from like once a month to every day. I think I had also been taught like EKG is really important as a before you're initiating methadone, and it is. And I think especially in the higher doses, it's important to get an EKG since there's some QT prolongation effects. But I think that can be another barrier to treatment and isn't necessarily like needing to be done initially. The difference between buprenorphine, like I already said, methadone doesn't require someone to be in withdrawal for initiation. However, it is a full agonist and therefore it does not have that protection against overdose if someone were to use fentanyl on top of the methadone. I saw a patient at the Alcohol and Drug Treatment Center who we almost gave him Narcan just because he had taken morning methadone and then used fentanyl. And then the dosing, it kind of takes longer for people to get work their way up to that therapeutic dose because methadone has such long half-life and can dose stack. So it's just not as fast of a titration usually as buprenorphine would be. In terms of barriers to care, none of these are novel concepts, but just to talk about them briefly, transportation. There was this one lady that would travel like an hour and a half to the methadone clinic. I think she was only once a week dosing, but in rural areas, this can be a huge issue for people where methadone is what works for them, but they don't, they have to drive like an hour. That really is a lot. And if they can't make appointments, like due to, the bus line not working or they can't afford, like I think that particular lady would know that how much money she made a week, she could only afford like 2 Ubers to come to the methadone clinic. And so she was always like missing one of the dosing. And so I think that's important for you as the physician to know, like, what are the patient's barriers to care and put that into context. It's not that they're just not showing up for dosing because they don't care. Finances, I mean, that is just kind of common sense, but just really having the ability to take care of yourself while you're going through recovery and do all the self-care stuff we talk about and access therapy and all of these things. And then housing, having a stable place to put your stuff and to live and shower and all of these things. Cannot stress how important that is. I had a patient that was living behind PetSmart, and that was just so destabilizing for him. And it's hard to give someone kind of the like advice we do, like I was just talking about with self-care and routine and some of the other things that can help stabilize someone when they're trying to reach recovery, if day to day they are figuring out how to meet their basic needs. Insurance, we had one patient who got headaches with with what we thought was maybe the naloxone component of Suboxone, but then the insurance wouldn't approve Subutex. So just kind of, weird things like that. And then the stigma that so many people experience and have internalized, I think has led to a really valid mistrust of medical offices and providers specifically, and can lead to, maybe not sharing certain information or just not wanting to go to the doctor in general. A word on safety-focused care. So the idea that people are going to use drugs and going to return to use, and their goal might not even to be completely abstinent, but our job is to meet them where they're at. Often at the methadone clinic, there would be patients where they were like, hey, these are our safety-focused care patients, where we know that they're at this point, like they are not trying to not use fentanyl at all, but we are trying to reduce the amount of fentanyl they use. And again, that's a win because it's less amount of times they're injecting drugs and less amount of time they're at risk of overdose. And so like that's a win, and you keep prescribing it. And that's kind of at provider discretion of how comfortable they feel with that. But just to say that some providers understand and are okay with knowing that a patient's goal is not to completely abstain from use at that time. Knowing where the needle exchange is, because truly Hep C, HIV, and endocarditis can be add so much on to an already complicated chronic disease of addiction. Already talked about the methadone point. And then, knowing your local resources of needle exchange, the paramedics and free clinics, and just places where people can feel safe and have people really care for them outside of just a medical clinic, and knowing where to get the clean needles, I think, is really important. They also will sometimes have other things they can get there to use drugs safely. This article really annoyed me. I saw this, I'm part of this like methadone group, and they sent out this email with this article and from the New York Post. And I think just the idea that this was talking about a safe injection site in New York City, and just the language in that, I think we would never talk about people using insulin in that way, like jabbing themselves with their insulin needle. And I think there's still a lot of like not in my clinic. And the reality is those people already are in your clinic. Most people see patients who are using drugs, even if that hasn't come up yet. And the idea that these people, you don't want them in your clinic for whatever reason, and it comes from a lot of stigma. And I would like to think that people came into medicine not to choose what type of patients they want to see. That's not why I came into medicine. And I think these people have so many barriers to care, and I don't think, truly they need the most amount of options of where they can go. I saw an inpatient IV drug use protocol during one of my rotations that was interesting, where people get their phones taken, don't have any possessions, and can't have visitors. Then the physician would have the ability to like bring back some of that and roll it back. And if they have like formed trust with that person, and I had a patient tell me like that felt like prison to her, and she'd been to prison before. So I think just, there was someone that had OD'd in the hospital, and I think that's where that rule came from. But again, just kind of that isolates them, and it wasn't even really explained to her that that was going on. So there is just still stigma and pretty harsh policies in place to kind of make people who are using drugs not have optimal care. And then something that you'll see is people who are using drugs often have their own internalized stigma, especially about being on Suboxone or methadone, starting it or being on it long term. I think it can be really helpful to remind people of the difference between addiction and substance use disorder versus dependence. People who take high blood pressure often take high blood pressure medication, often take it for the rest of their life. Same with people that take insulin or thyroid medication, or even steroids. When you stop steroids, you can have, pretty bad effects. So reminding them like, hey, this is a chronic disease like other diseases that we all, a lot of people know about, and it's okay if you are on this for a while. And when you are using this medication, you're not using despite consequences and doing unsafe things to get this medication, injecting it, all of those things that made addiction hard, or made that drug use negatively impacting your life. There's a dependence to this, yes, but it's not coming with all of those impairments and distress that define the use disorder used to have. And empowering people with that reframe and that knowledge, I think, is really important. This is one of my favorite social workers in New York City. He's like a safety-focused care person that posts a lot of great things. And it says, fun fact, when you don't automatically treat someone's drug use like a problem, it's easier for them to ask for help if it starts to become one. And I think that just speaks to the way that you phrase questions like, oh, you don't use drugs, do you? Versus like, hey, so tell me about any drug use, and the way your body language and, facial expressions are when people tell you if they do use drugs. I think how you set that tone really will affect if they feel safe talking to you about things once they become a problem. And we had one patient who was using meth, and he just did not feel like it was affecting him at that point in a way that he wanted to make it a goal to stop using. And we always talked to him about the risks of using meth, but it was never a thing. Like, he felt comfortable sharing with us his use and that he wasn't planning on stopping anytime soon. And I think that was because the NP I worked with just set up a great relationship and tone with that patient that made him feel safe talking about that. Recovery looks so different for each person, and that is something I truly appreciated after this rotation. Some people, it is abstaining from all substances. Sometimes it's just using less, or not using IV. And for some folks, going to inpatient detox is what works for them. They need to be in this controlled environment with, micro induction, or, if they know themselves well enough to be like, I can't do this on my own outpatient, then like inpatient detox can be a really good support. They have a nurse there, people who are giving them clonidine and hydroxyzine and these other things. I think I had my own bias about work programs. I was like, oh, that's, they're just using these people for labor. But for some folks, like, work is something that gives them purpose, and to be able to go do that and have a stable house and place to live that's substance-free is really meaningful and helpful. And so knowing that, like, maybe you didn't imagine that would be something good for people, but acknowledging that, like, yeah, every program is going to have some people that program works for them. There are a lot of great sober living facilities and halfway houses in Asheville that really helped provide a therapeutic kind of living space for folks to not use drugs, and they'd have peer specialists that lived there and therapists, and really support those people as they transition back to living on their own, kind of in the real world. This was one of my favorite things I did. It was kind of like part of the elective and also not. I sought out this volunteer opportunity because I had some friends who did this. This is the Mutual Aid Wellness Collective, and it was started in the wake of Hurricane Helene. It's doctors, nurses, and paramedics who wanted to bring care directly to folks, especially those who are unhoused. And where I'm at in this picture is a place called 12 Baskets. It's this wonderful place. It's part of the Asheville Poverty Initiative, I think, where people get free food and hot meal every single day, no questions asked. There's also groceries that people can get, and such a community there where those portraits, like back here, these people have been coming to 12 Baskets for years and are just like pillars of the community. Our role here would be to provide first aid. We do a lot of wound care, gave wound care kits, as a lot of these people had xylazine wounds, or I even tended a wound where someone had dropped the fentanyl foil that they were using on their stomach and had a pretty gnarly wound. We can kind of keep people from going to the emergency room. There was one guy that was like, I need help. I need to go back to the emergency room to know what dose of Tylenol to take. And we were like, well, we've got great news for you. We can tell you that here. And then we had a lot of stuff to give people too, like sunscreen, eye drops, different over-the-counter medications. We can do some prescribing. The nurse I'm pictured with here would do some antibiotics if she felt like it was a slam dunk pneumonia. We don't really do that much else for prescribing. But there's some people that really want their blood pressure checked every week. And so we would do that, do physical exams, and then determine, if they do need to go to the hospital. And then we would work closely with the paramedics and the post-overdose response team, which I will talk about in a little bit. So street medicine, I think this is the best idea, and I hope to get more exposure as I am in residency. The highest risk patients are often the ones that you are not seeing in your clinic, but they can be frequently engaging with emergency services like firefighters and paramedics, EMTs. And so this Buncombe Bridge to Care program had this wonderful idea of like, if we tried to link people to care through that first touch with the emergency services, what would that look like? This program sadly doesn't have as much funding as it did initially, but I think it's a good model for care, so I still wanted to bring it up. They used a grant to kind of cover the services that would go from the EMS person contacting the patient, and then all the way to getting that patient into recovery or into substance use disorder treatment, if that's what they want, in a clinic setting longitudinally. They would pay for the medications and visits. They would provide them with a peer specialist that would follow them, I think, for up to 6 months. They can provide rides and bus passes, help them apply for food stamps and the specific Medicaid that folks can be on for like mental health and substance use disorders. And then even a phone with prepaid service, since that is such a huge part of, recovery in this setting, is being able to contact your peer specialist or your doctor. And so really trying to hit as many barriers to care as possible through this program and give people the best chance to recover if that's what they want to do. This is a schema of the model. So it's not only post-overdose, but I think the idea is, if they've resuscitated someone and then they can immediately give them buprenorphine, and then they can dose that person for, I think it's up to 5 days. I don't remember specifically if they give them I think it's every single day they come and dose that person. I don't think they give them 5 days worth, but they can kind of dose that person until that person gets to MAHEC, which was the clinic that I did my family medicine rotations at and did the office-based opioid treatment at. If they wanted to do that, EMS would connect them with the peer specialist, and then that person would refer them to MAHEC. And so as you can see, it's this stepwise fashion of meeting people where they are at in the community with people that they don't have to go to a clinic. They might feel safer. And in my experience, they had great relationships with the EMTs and paramedics. People really saw them as part of the community and non-threatening. And that is such a great way to access patients and gain their trust, and then try to connect them to the point over here where they are longitudinally in a program and have providers that are prescribing them meds for their opioid use disorder if, upon initial intake, that is something they want to work towards. I'll talk about 2 different patients that were impactful for me. This one, Mrs. C, this was at 12 Baskets. She just did not look herself one day, and I kind of asked what was going on, and she said that she was not able to make it to an appointment in South Asheville where she gets her buprenorphine prescribed. And I was kind of to myself thinking, that's such a faraway clinic. I wasn't sure why she goes there, but she was in withdrawal, and I said, how would you feel about me calling the post-overdose response team? They can dose you for 3 or 5 days and maybe get you connected, contact that provider and explain the situation, or even get you to see someone maybe closer by. And she said yes. The post-overdose response team came so quickly. She got to sit in the cold car. It was the hottest day ever. And they dosed her and ended up connecting her with a different office where she could get prescribed buprenorphine that was closer by and more accessible by bus. And there's this awesome nurse practitioner that does a lot of street and community medicine through that center that it's called the Daleville Center. That's this clinic. And so they connected her with that nurse practitioner specifically. And so that way there's someone that can come to this patient in the community, and also this patient has a new established clinic to go to that is closer. And that just felt like such an amazing, there's a resource, I accessed it and used it, and they showed up and were kind, and this person got to feel better. And sometimes it just feels like that doesn't happen enough in medicine. And so when you have things like that, it's okay to think, just sit in it and be like, I'm really grateful that the resources that I've been given, I can use them and they will work. This was that patient's husband, actually. And this was someone who had been unhoused for many years. He used meth primarily as a way to kind of survive on the streets, stay alert, stay awake. He kind of viewed himself as a dad in the community, very protective. And, that is how he has found meaning in the space that he's in. He really wasn't super interested in stopping meth, but was kind of like, I don't like that I feel bad when I don't have it. And I just kind of use it, for the reasons I just said, and because it's around. And that person would, one day he asked me, like, do you go to the inpatient treatment center? And I was like, yeah, I go there on Thursdays. And he was like, okay, well, maybe I will go and get some detox there, since that place also does methamphetamine detox. And sure enough, on Thursday I went, and there he was. And there was just something so special about having seen that person in 12 baskets in a completely different non-clinical setting, to then seeing him in like the scrubs and the little shoes and having him there. And he was so excited to see me, because I think those centers, it can be really overwhelming. You have all of these new people, and he was really scared to know about how his heart failure was doing and didn't want to get labs. And by taking the time to talk to him, and because I had established that rapport, we got him to get his morning labs. But the thing that feels most real about this anecdote, though, is I went to 12 baskets on Friday, and sure enough, I walked in and there he was. And so he'd already like discharged himself from detox. And that's just life. I think patients are on their own journeys, and you can only support them and be there for them wherever they're at. So I, was ready to be there for him in the inpatient setting. And then now I'm here back at 12 baskets, and we're talking about his hypertension again and how he doesn't take medicine for it. So I think that was just showing patients that you will come to them and be in their environment, not just them coming to you. You establish a type of trust and relationship that truly is so important. The gap in care for adolescents, this kind of relates to why I'm applying into medicine and pediatrics. The intergenerational patterns of substance use I saw were so severe. People, even at age 14, using with grandma or grandpa. In Appalachia, this is really common. And I often thought, what if we had accessed this person earlier? What if this person had been on buprenorphine earlier? Maybe he wouldn't have Hep C now at 20. In North Carolina, the only inpatient place minors can go to detox is the hospital. In terms of outpatient detox, it's just not widely practiced, but you can do it. For methadone, you have to have a state deferral for 16 and 17-year-olds, but buprenorphine is approved for 16 years and above. So this is something I hope to gain experience in and feel comfortable doing, so we can try to, intervene earlier for people that want to be in recovery. Know your resources. This has been a huge theme, but working with case managers and social workers, they often have great documents or lists or handouts for patients, but in the case that person's not available, just having your own printouts and or having those resources from them in your hands to be like, hey, here are some places you can go to get hot food, to get clean needles or whatever. I think it's important that you show patients you care about their whole being and how their life looks outside of the clinic, and you've thought about those other, social determinants of health, and have resources for them. And especially have thought about, if those resources would work for that person or maybe not. If it's a religious place, you might not recommend that for someone who's had religious trauma and doesn't, don't recommend. It's just helpful when there's some places that are more religiously affiliated for treatment. And I think that's just a note of understanding and personalizing the resources you give for people. Sunrise community recovery was just the best experience. This was I'd go there on Wednesdays, and they're a peer recovery group that is staffed by peer specialists. They are all people that have had lived experience with drug use or severe mental health. They have this amazing drop-in center where folks can come and get resources for housing and transportation. They have NA and AA and all types of recovery sessions, group therapy. Another thing I really liked that Sunrise had is this Blair Clark respite house. And it was a place where anyone who needed a timeout, so to say, from emotional distress or their current circumstances could go there for, I think, up to a week. And a peer specialist is there during the day. There's some food there and resources there. They have their own room. They can lock the door. And I think this is just, so many people need this, and there's not a number of time, like there's not a limit on how many times a person could use this place. And just when I went there, it seemed like these people truly, I mean, everyone deserves to have a place like this in a home, but we have to acknowledge that that's not our reality right now. And so to establish a place where even just for a week you can give people that environment, I thought was just so cool. There's a new place called Kevin's Place Bridge House. That's kind of a transitional home for people with severe mental illness that are coming out from inpatient, and it's going to help them kind of get back to a place where they will gain the skills and be able to transition to living on their own successfully and independently. So that was a new place they were working on, and there was a peer specialist who'd be working there at all times and kind of helping those folks, and it was a really nice house. And then as we're close to Cherokee, and we have an Indigenous population there where there is a lot of drug use. I don't really talk about racial disparities here in this talk, but there are tons, and Indigenous people have a disproportionate amount of addiction, and I think they don't always get the care that other groups get. And this specific center is staffed by people that are peer specialists and members of the Eastern Band of Cherokee Indians, and kind of provides like a specific place for them. And I thought that was really important and cool to see. This is just a brief sample of like what Sunrise Peer Recovery Center looks like on a weekly basis. As you can see, there's different art and recovery groups, wellness groups, you name it, just places for people to, be inside on a hot day and have people who have lived experience kind of be there for them and give them whatever resources they want. They also, what I really thought was cool, have this program where they help workplaces become recovery friendly, meaning that they are educated on what recovery looks like and can better work with people who use drugs and help those people retain their jobs. And that is really important. And I was like happy to know that a lot of these businesses in Asheville are recovery friendly. And they even have a program specifically for more rural counties where those to help businesses there get established as recovery friendly, and to help people who have a history of substance use disorder find employment that will be good for them, and like, again, that their employer will have the context and education and compassion needed to kind of retain people that have used drugs. Kevin and Amy are two people are very dear to my heart, and I asked them, like, what would you want medical students to know about peer recovery? So Kevin, he says, avoid being traumaphobic at all costs. Medical model is good for finding and fixing symptoms, but peer specialists regards recovery as a personal, social, and holistic journey. Together, they can provide stabilization and meaning, connection, and hope. And then Amy wants us to know that what a critical role peer supports play, and that recovery or receiving care and health services is important, but having someone on your side who's been in your shoes is invaluable. So again, speaking to the lived experience that peer specialists bring and the holistic focus of these services. A word on some of my biases as well. I think I went into this as like thinking I was a pretty, like, how do I say this? Non-judgmental person, and just thinking like I am pretty accepting. There's nothing that would shock me. But there were a few times during this rotation where I caught myself being like, wow, this doctor really, doesn't think this person has used alcohol. It's come up so many times on the drug screen now, or the urine screen, and he's here telling them to, going through their whole diet of what they're eating and what hand sanitizer they're using. And I kind of felt myself like, okay, it's probably just that they're lying. And just checking in with yourself and noticing, like, we all have biases, and sometimes you don't know them until a situation brings them out. There was also like a fentanyl brownie patient where he said he accidentally ate this fentanyl brownie. And I think just making, like, my job is to take people at their word. And I definitely think that I got better at that. And just all you can do is acknowledge. You don't have to make yourself feel bad for the biases, but you can work to notice them and then not act on them, and just always ground yourself in believing the patient when you talk to them. And like, I think that will get you pretty far. A word on being back in my hometown. I grew up here in Asheville and had some friends pass away, one in particular at a younger age from addiction. And at that time, I didn't really understand the amount of services and support that folks struggling with addiction have in Asheville. So it felt like an honor to, as a medical student, be back in my hometown and be a part of this amazing community where everyone knows Paramedic Dave and everyone knows 12 Baskets. And there's just so much support. Like, it would make me tear up just thinking about it, that there's room to grow, yes, but Asheville has just done so much for these people. And to see some of these programs and how accessible they're trying to make things, I just didn't know all of that existed when I was younger. And I think about my friend and, wonder if she had known about these services. And just, I don't know. It just was like touching, and I felt really blessed to take care of these folks in any way and kind of give back to the community that raised me. Sorry, that's my cat. As a medical student. All right, so that is the end of my talk. Any questions now?
So that was great, Courtney, and I appreciate all the efforts that you made to going into giving this presentation, and really some insightful ideas of what you experienced during your elective. So I will say viewers of this program are welcome to write us with comments or questions that you might have about addiction medicine education, electives that you may be thinking about starting or experiencing as a student. As we think about this, and I think I know the area in which Courtney had been working, and the idea that that a student like Courtney would have this opportunity really to experience out in the field what patients are going through, and just learning more about the social determinants of health that are associated with drug use, and how they can have a play, and the difficulties that people might have in getting into a stronger recovery. So I don't know, Courtney, you really did a very nice job of describing those things, and and I think for people to be thinking about that as they start to interact with folks with substance use problems, I think it's just really important that they keep those problems in mind, and recognize that there's a whole lot of reasons why people start down the path of potential difficulties with their drug use. So again, I thank you very much for taking the time this morning to present.
Yeah, thanks for having me.